let you and your friends all know that you can revisit this at any time. So I want to acknowledge that we're hosting this session on the unceded and ancestral territory of the Coast Salish peoples. That includes the territories of the Musqueam, Squamish, Tsleil-Waututh nations and the Métis Chartered Community of Lower Mainland region. And as we approach September 30th and the Day of Truth and Reconciliation, I think I encourage everyone to learn more about the peoples of your territory, and the land, and to respect elders past, present, and emerging. Next slide. So province-wide rounds, and this is our first one of the academic year, is a collaboration between the University of British Columbia and BC Renal. We're very indebted to our corporate sponsors, as well as all of you and the different health authorities around the province of British Columbia, listed here on the bottom of the slide. Next slide. So it's really a privilege and a pleasure to be able to introduce Dr. Aminu Bello and Dr. Somkanya Tungsanga. Dr. Bello is a professor of medicine at the University of Alberta and a consultant nephrologist at the University of Alberta Hospital. He comes originally from Nigeria and completed additional training in internal medicine, nephrology, and epidemiology in Nigeria, the UK, and Canada. His research work has been funded by national and provincial funding agencies, including CIHR, and his focus of his research is rooted in health equity with a strong focus on improving access to and quality of care for disadvantaged populations, in particular Indigenous peoples and people living in remote and northern communities of Alberta, which he goes and services on a regular basis. He co-chairs the International Society of Nephrology Global Kidney Health Atlas, which is what he's going to speak about, and is a mentor to many, many people, one of whom is Dr. Tungsanga. And she's a nephrologist and researcher with a dual appointment, both as a postdoctoral fellow in the Division of Nephrology and Immunology at U of A, but also an assistant professor and consultant at the Division of General Internal Medicine and Nephrology at Chulalongkorn University Faculty of Medicine in Bangkok, Thailand. Her contributions to the International Society of Nephrology's Global Kidney Health Atlas have earned her the title of a named fellow of that ISN-GKHA from January 2023 to December 2025. And she really has almost single-handedly, with the help of Aminu, led the development of the interactive map, which hopefully we'll be able to see, that visually highlights those global gaps in kidney care. And her research focuses on chronic kidney disease and care disparities. So with that, I really am thrilled to be able to introduce Dr. Bello and Dr. Tungsanga to lead us through Bridging Global Gaps as our first endeavor into this academic year. So over to you guys, and you've got a full-on audience of over 50, almost 60 people. So over to you guys.
Thank you. Thank you very much, Adira. We thank you. We thank the Division of Nephrology at the University of British Columbia for this great opportunity to share this presentation with you. This is particularly important, particularly that it's the first grand round, for the academic year. So what a great privilege and opportunity you afforded us. So the topic today is on bridging global gaps in kidney care, giving you some insight of this important international initiative being driven by the International Society of Nephrology. So this has a learning objective to briefly introduce to you the Global Atlas and what it does, the key goals, the key findings and implication of those in clinical care and guidance of policy making at national and international levels. Next. Next. So I'll take you a bit of history. Why the Global Atlas? We all know that at the beginning of the century, so much information has already accumulated regarding the epidemiology of chronic kidney disease, the burden, the population distribution, as well as impact on population health, risks of kidney failure, cardiovascular disease, and so on, development of treatment. But what was not known was about how the care for the condition is organized, structured, and delivered around the world countries and region. And part of the initiative during Dr. Levin's presidency of the ISN, international stakeholders across the global kidney care community, including patient practitioners, policymakers, assembled there in Vancouver in 2016, convened under the office of the ISN to really develop a roadmap to define CKD care, research, and advocacy into the future. And ISN has already developed that Closing the Gap initiative, part of which was the need to really map kidney care worldwide in terms of how it is structured and organized over the several decades, essentially highlighting the readiness, capacity, and access to kidney care across the spectrum. And this was built on a validated framework, international framework, using the World Health Organization Universal Health Coverage Framework, covering the essential elements of sustainable and effective health system. So that was the beginning of the atlas. The seed for it was planted there in Vancouver, developed, and were charged to lead it and deliver it over the subsequent years. So the key goal, like I said, was really to define the global status of structures for kidney disease care, how countries detect, treat, monitor, and advocate for people living with kidney disease across the spectrum from prevention, monitoring, to how care is organized for people living with kidney failure, meaning dialysis and transplantation, including conservative kidney management as well. So, the running of the project was done in an academic, robust way that include very extensive depth research, literature review, what is out there already in terms of gray literature, published scientific literature. So we conducted systematic reviews, Scopian reviews of different areas of elements of kidney care. For example, estimate on cost for dialysis, how much nations are investing, spending to provide dialysis transplant care. We on workforce, what has been published already, then that was supplemented now by a survey using a validated questionnaire translated into 3 major languages, English, French, and Spanish. And that was distributed to stakeholders across countries. And these are people deemed to be knowledgeable, or they are directly involved with delivery and organization of kidney care in their countries and region. So essentially, most of them are national society leaders in nephrology. For example, Canada will be the president, secretary, top official of the Canadian Society of Nephrology, for example. This was done and sent to almost all countries of the world, collating information on kidney care organization, structures, and delivery. Next. So, like I said, we have an excellent comprehensive representation of all countries as well, with our surveys including almost all nations. 100 in the last exercise, 167 countries were represented. That constituted almost 98% of the global population. Most importantly, this was also very, very inclusive. We included almost all low-income countries that are labeled as low-income or low-middle-income countries who face the greatest challenges in kidney care delivery and organization. Next. So we try to make the results meaningful, useful, and pragmatic for countries and organizations like not just the ISN driving the project, but also other international stakeholder organizations, particularly the WHO. So we normally do the results by ISN regions, for example, Africa, so that people can see what the challenges are, apart from global summaries and how regions compare with each other. How does North America, Canada, US compared with Australia, Western Europe, for example, or how does low-income nations like Africa compare to South Asia, for example? What are the challenges and what can be done about them? Next. So we'll also try to present results also by relevant income grouping, aside from geography, mainly to highlight where the major challenges are, and so that data could be used for advocacy with international stakeholder organization. And that has happened, as you will see in subsequent presentation, how the data from this exercise has been used at various levels, international, regional, country level, to change or to advocate for change in the landscape of kidney care around the world. So at this point, I will now hand over to my colleague, Dr. Somkanya Tungsanga, to take you through the major summary of the results and their various implications.
Thank you, Aminu, and also thank you, Adira, for your introduction. So from our global survey, let's see what we found. Okay, there are more than 850 million people living with kidney disease, and that means roughly 1 in every 10 adults is affected, with the prevalence around 10 to 12% in most regions. And the data, the impact is increasing. By 2017, about 2.6 million deaths were due to kidney disease, which is 42% increase from 1990. That's a big number, making CKD now the 12th leading cause of death globally. And while this CKD reaches kidney failure, the economic burden is significant. In-center hemodialysis costs about 19.8K US dollar annually per patient. And peritoneal dialysis is slightly less, around 19K US dollar as well. We can see that the median cost per capita for kidney replacement therapy is generally lower in low and lower middle income area compared to the high income countries. And this could be influenced by factors such as the use of more advanced modalities in high-income countries, or the practices like reusing dialyzers and equipment, or low infrastructure costs. Unfortunately, we didn't go into granular detail, but these are hypotheses. However, the costs do not necessarily reflect the quality of care. For example, in parts of Oceania and Southeast Asia region, where PD is more prevalent, overall costs are reduced because logistics are simpler as well, not because the care is compromised. And as well as the cost for KT medications, which is close to 27K in the first year post-transplant, which in low-income settings, these costs are simply not sustainable at all. And despite the high burden, fewer than half of countries provide government funding for dialysis. Only 45% cover hemodialysis. 42% cover peritoneal dialysis, and only 36% provide funding for kidney transplant. So for many patients in many countries, particularly in low and lower middle income countries, life-saving therapy depends on their ability to pay out of pocket as well. And when we look at the service availability, hemodialysis center exists in 98% of the countries, but density varied widely, which means that they might technically report availability, but may not be accessible in remote areas within one country. PD centers are present in only 79% of countries and 70% for transplant centers with much lower density. And when we compare high-income countries on the right, they have up to 31 times more dialysis center per capita than low-income countries on the left. In terms of transplantation, donor sources also vary. High-income country has a balanced mix of living and disease donation, which we labeled in blue here. But in low and middle-income countries, living donation dominates and limited disease donor programs. These mainly involve lack of workforce and capacity of organ procurement and allocation. And talking about workforce, you can see that high-income countries have 84 times more nephrologists per capita compared to low-income countries. And even when we look at the upper middle-income countries, the ratio is still more than double. And nephrologists are not the only gap. Over half of the countries report shortages in nurses, surgeons, dietitians, technicians, etc. And this highlights that workforce development is a critical bottleneck for improving kidney care globally. So in summary, for the low and lower middle income countries, the prevalence of treated kidney failure is far below the global average. Even the burden of CKD is high. And disease donor kidney transplant is rare. The public funding for therapy and medications is still limited, and workforce shortages are critical. And we see over 800-fold variations in treated kidney failure worldwide. Kidney replacement therapy is often not available, not accessible, and not affordable in low-income countries. And for people living with kidney disease, the consequences extend beyond health. It's the ability to work, the mobility, and financial hardship are the major concerns. So from all these findings, we have our reports published in the high impact journals from the pilot in 2017 to the 2019 and 2023 iterations. And each iteration has expanded scope and moved beyond data generation. We also publish our perspective and commentary papers as call to action pieces and to advocate for urgent action. And collaborations with other organizations as well. These papers work with the University of San Francisco to explore the benefit of expanding transplant program. We also established the ISN-GKHA fellowship program for the workforce development in many parts of the world. So despite a lot of things that we have done, now we have extensive data. Our main goal, which is the major goal for the education, is not just to collect the information, but to drive into the policy change that really leads to the real improvement in kidney care. However, policy change is complex. It requires multiple factors working together and collaborations on a larger scale. So we aim to reach a broader range of stakeholders, including the public, the policymakers, and health organizations, by making our data more accessible, simple, and comprehensible, which becomes the concept behind the ISN-GKHA interactive map, which I will show you later in this session. A key milestone in the past year is the engagement with the UN and WHO to promote kidney care. We start by presenting our data at the 79th UN General Assembly last year. And in this May, the 78th World Health Assembly passed the first ever WHO resolution recognizing CKD prevention and control. This is a formal acknowledgement of CKD as a global health priority. The resolution calls on countries to provide funding in prevention, early detection, and management, to include kidney care and universal coverage, to apply WHO baseline interventions, which is aimed to prevent and manage non-communicable disease, to monitor burden, outcomes, and access of CKD, and to promote cross-sector collaboration for sustainable kidney care. While GKHA will continue to monitor changes and track progression over time. And this will complete the resolution, action, monitoring, which will lead to the better outcome. This builds on the 2017 Mexico Declaration, which outlined 10 global recommendations for kidney health, from prevention and awareness to equitable care, to expanding transplant program, and to supporting research. The WHO resolution reinforces and strengthens these commitments. The other tool that I would like to introduce to you today is our ISN-GKHA interactive map. So you can get along with us by scanning this QR code or entering this URL. I'll give you guys like few seconds in case you want to scan. All right. So when you first open the website, you'll be greeted with the about and instruction pages. So you have like what is our website and how to use the atlas. We'll briefly lead you through like how to use the website. And once you go through this, you'll be directed to the map, which you can view the data by indicator, by country, ISN region, or World Bank income group. So let's start by selecting by indicator. And now on the left, you will see a panel where you can select or search for category or specific indicator. Like we have like the name of the category, and in each category, we have specific indicators where you can explore. Like availability of dialysis facility, we have either in-center or PD. So now I choose the prevalence of CKD, which is now displayed on a world map using this heat map coloring, meaning that the paler to the darker colors represent lower to higher prevalence accordingly. And this gives us a quick global overview. Beyond the name of the indicator, which is labeled up here, you will see that we provide the description of each indicator in a comprehensible language, like not the technical term, so that we can reach the audience that is non-medical, like the public or the stakeholders. We also summarize the key finding here, like for each indicator, to make it more comprehensible, to make them understand what is actually showing in this figure. And as I hover over the country on the map, data of such country is shown. You can also compare between different years based on the iteration of the GKHA reports by dragging these sliders. We only have 2 right now. Yeah, over the year, yeah, to compare between years, between iterations. Or you can even use this play button to watch the data change over time. You can also toggle to view the data of country by country as a table, which will order from higher to the lower data. And if you like, in case that you want to use this data or this figure for your presentation, you can simply click download here to get this data as a CSV file or an image. Now let's change to view the data by country. You can select or search for the country here. Like we have a lot of country, like all the country level by alphabetically order. And then you can select the year that you want. For example, select Canada for 2023. Here, you will see that all the available indicators for the country is shown here in one place. And again, we have the description for each variable. When you hover over this like information icon here, it will label what is the indicator. And again, here you can comparison. You'll see a barcode plot where the selected country is labeled in color, and we'll compare against other, including the global median. We have the big line for the global median, like here, and which will be labeled as a global median. And when you hover your mouse over each country, you will see like briefly which country is like closely to your value in each country that you want. And how about the ISN region? You can search for the region as well. It works the same way. We'll show you on the map and the year over here, and everything works like almost the same. And this applies to the World Bank income group as well, where you can compare to other income. All right. So in summary, this interactive map not only provided data on kidney disease burden, but also on the capacity and quality of kidney care. And by combining these two aspects, it gives a fuller picture of the challenges and resources available in different regions. You can explore the data at different level to suit your needs, whether it's a global overview, the regional or income group comparison, or even an insights at individual country. This is particularly useful for comparing regions or country that share the similar healthcare context and identifying gaps of disparity. The ability to look at changes and trends across different iterations will let you see how kidney disease burden and care have evolved. And with each new data iteration, the map will enhance the ability to show evolving patterns and refine the understanding of where the resources and policies are most needed, which means that with more iterations to come, our interactive map grows stronger. And the map also let you explore the interactive data visualization for easy interpretation with such feature and data export. And good news, we have a mobile version where you can have this spinning globe on your device. You can try it on the mobile as well. And our website also open for feedback where you can input your feedback here. So it's just the beginning of us. So please visit it and help us improve it. What I want to point out is there is still a challenge to consider. For example, you may notice, even from the report or from our map, that the prevalence of CKD in some certain areas appears lower than in most regions. For example, here I select the data from South Asia, and we'll see that the prevalence of CKD in South Asia is even lower than Western Europe or other country, like much lower than the global median here. However, when we look at the map, you will easily see that in the area of South Asia, there are lots of missing data here. And it's important to know that low disease prevalence may not reflect the truly low disease burden. In fact, it may reflect underreporting in many areas. So these are the field that we are trying to improve the data quality for more accuracy. So in conclusion, over the years, the ISN-GKHA has grown from being simply a survey into a global platform for kidney health advocacy. And it now serves not only as a data source, but also a driver of publications, collaborations, and at the end of the day, the policy change. We also helped monitoring and track the progression with all those actions. We plan to track the data every 4 years, and the next iteration will be in 2027, which will mark exactly 10 years since the first launch of the atlas. Despite the passing decade, our goal remains the same, is to bridge the disparities and move toward equitable kidney care for all. And we hope that Global Kidney Health Atlas can serve as another important step toward closing the gaps in kidney care worldwide. So let's making a decade of ISN-GKHA together in the next iteration. I would like to acknowledge the ISN-GKHA working group, our colleagues, the partners who have worked so hard to make this happen. One of whom is Adira here. Thank you.
Thank you, Somkanya and Aminu. There's a lot of heavy lifting that goes into this Global Kidney Health Atlas, and I think it's an amazing resource. And I think one of the things that people should appreciate is that while you've given us the high-level overview of what is and isn't available and the differences between the groups, there's also additional, there was a nutritional supplement at one point. There are ongoing additional information that people can actually get out of this. And I think it's an amazing resource. So thank you for all the work that gets done at, as a collaboration. Open for questions. I think and Somkanya has done amazing work working with Aminu and getting this interactive map, which is quite an impressive thing. Happy to answer any questions that people have or any additional comments that you two would like to make. I'm trying to manage the chat and the Q&A at the same time. Carolyn Stigant.
Yeah, hi. Hi to our guests, and thank you so much. It's really exciting to see the power of this and the reach of this and such unbelievable advocacy. So I'm really speechless seeing this in such a summary form because there's all these publications that come out of it. You likely know that I'm interested in the sustainability side of things, and I was reflecting on listening to your presentation that maybe seemed an unfair ask given that dialysis resources and even basic care is needed in so many areas. But I'm struck by this as an advocacy tool and as a really effective way to display a lot of data to industry, for example. So I wonder, I'm just thinking about the sustainability reach in that, if you see a role of maybe expanding some questions and your thoughts about how questions are incorporated and designed, length of survey, practical points for someone who may like to get an aspect of kidney care on this global agenda.
Maybe I can start. Thank you very much. Thank you for that very important insight. So when we started in 2016, 2017, in tandem of that global roadmap on kidney care research policy advocacy in Vancouver. So the GKHA at that time was conceived essentially to provide broad-based information about how kidney care is organized across all countries and region. Across these pillars is research, because it's supposed to provide data-driven foundation for regional variation in not only disease burden, which some of it are available in registries, but also access to care across the whole spectrum of kidney care, from simple diagnostic, availability of serum albumin, availability of serum creatinine, to availability of transplant centers. And with that information, we're able to do comparative health system studies, comparing how countries are performing, how regions are performing. So this makes this exercise now the most robust repository of health system data for kidney care across the world. So it provides the information for longitudinal monitoring, measuring changes over time. So we try to measure, okay, this X number of countries have no capacity to measure its urine albumin, for example. After 2-3 years, we go back, remeasure and measure, see how structure for kidney care change over time for countries, from basics of diagnostics, essential medication, kidney failure treatment, provision, and so on and so forth. So the goal is this longitudinal monitoring of standards for kidney care, if you like, across the spectrum. Over time, there are areas of higher priorities, additional priorities identified. For example, I did mention about nutrition, where we collaborated with the International Society of Nutrition and Metabolism with Dr. Angela Wong, and now included some cyber aspects about capacity to deliver nutrition care, deliver nutrition services, and so on. Later on, also, we touched a little bit on sustainability, on environment, but this is impact of climate on environment, on kidney disease, the so-called CKDU, chronic kidney disease. So we did incorporate some questions around that in the second iteration. But what we have not covered is this important element, the intersection of kidney health into climate action. For example, it will interest the world to know how countries are doing regarding reducing greenhouse emission, for example, improving basic things, improving air quality, ensuring water safety, and how that we all know it will relate to low risk for kidney disease. And that now intersects regarding sustainable kidney care, as you did allude to, the need for innovation in green dialysis technologies, water recycling, and so on, renewable, energy use in renal units, integration of kidney health, even as simple as policies. We ask people about, do you have a CKD policy? If you don't have, do you have anything, any mention of CKD in your national health policy if you have one? So now, if country will have, every country now, climate obviously is an important issue, but so we like to know maybe is kidney health really integrated or even a consideration in any climate action policy in your region, in your country? Is all those kind of high level questions will be obviously be of interest. And directly too, what about measurement for infrastructure disruption with climate events all over the world, like wildfires, right? So we don't know. Is Alberta having a policy, for wildfire? How does that compare to that of BC? Even here within Canada. So we can do that at national, international level as well. How countries prefer emergency preparedness for these climate factors, fires, water, air, water, and so on. So it's very important. So usually what happens if it goes to a steering committee, because Adira is here as a leader, we review is the topic of importance. It is within the remit of the GKHA. Of course, we rely on people to provide information, so we don't want to overburden with, survey fatigue. So we want to make sure it's within the remit. So obviously, climate is important. It has a significant role in kidney health, yes, definitely, and it's important to measure. So what happens if a group, within the kidney community comes to us, will be interested regarding this topic? We ask for questions, high-level questions. Then we discuss them in the, steering committee and see how does fit into the survey, and we now include them into the questionnaire and continue to work with you to refine the questions, to validate them, to make sure, is the question will answer, the intended measures that they are designed to measure. Adira, if you have any.
Yeah, no, I think that's great. I think, like, as you mentioned, across Canada, the diversity in kidney care policies, in the way things are funded, what's funded. I mean, even within our own country, there's huge heterogeneity in terms of our approach. And I think sobering for this audience, like the fact we have no national policy in Canada for kidney disease. It doesn't appear on anything. There's a national cancer policy, but there's no kidney policy, and people are working hard, using data and using things like this to try and get such a thing. It's interesting, Thailand does have a policy, and they do have national policies and well known to everybody, as does Taiwan and a few other countries. But interestingly, for all of our resources in Canada, we don't have such a thing, nor do we have provincial policies necessarily. So I think this sort of information about prevalence, what access to services, and to Carolyn's point, like these additional things like our commitment to sustainable kidney care, reducing greenhouse emissions, even as a country, we will not be consistent across provinces. So I think gathering data and then being able to work with it, and I guess a shout out to any of the residents and fellows that you're certainly able to contact Aminu and see how you might work with some of this data, be involved in some of the writing and understand sort of the totality of the data that's available. That's how Somkanya got there, and many other fellows have also worked with Aminu and his team because they have a huge amount of resources, and you can imagine the amount of data that's available across the world, but also within our own country. So really a shout out to the amount of the prolific nature of the documents that are published there, and all the really interesting information that's available. And Carolyn, we will get some questions about sustainable dialysis practices and everything else onto the 2027 one, I'm sure.
Oh, that's amazing. Okay, well, we'll stay in touch then. Thank you, and thanks for the really helpful answer and explanation of the process. Just excited to see that.
Thank you.
Great. Other questions or thoughts that people have? Availability of diagnostic testing. You will be perhaps surprised to know that not every country has the ability to do creatinine on a regular basis. This is to Somkanya's point earlier, like some of the prevalence data is because there isn't the ability to test, or there isn't a totality of commitment to understanding kidney disease in certain countries, so we're quite limited. And I think that's kind of important for us to think about. Okay, well, oh, sorry, there's two questions. Kevin, having WHO recognize kidneys global health is a great achievement with the various iterations of the atlas over time. Have you noticed any regions or countries that have significantly increased care funding, or national governments that have reached out to help? Maybe do one of you want to answer that?
Yeah.
Yes. Okay. Yeah.
I mean, you can, yeah, after you.
Okay. Thank you very much. Thank you very much, Kevin. Glad to see you. You've been part of the GKHA family as well. Thank you. But we lost you over to BC. That's okay. Yeah. So yes, and that's essentially the goal for the GKHA. So every time we publish all this global report, regions, Africa and Asia and America and so on, we'll also try to provide granular information by countries, what we call the scorecards for every nation that usually participate along the key element of our health system: availability of our workforce, essential diagnosis. These are basic: serum creatinine, serum albumin, and things. Essential medication, for example, RAS inhibitors. How the care structures are organized, and policy involvement, and important concept you brought in, funding as well. So we started to measure that with the first illustration in 2016. Then those are standard. That will not change. We are now talking about additional element of the survey, but there's also the standard survey or atlas parameter that will not change over time, just to give us the ability to measure all these changes. Yes, do we see changes over time? We do. Remember also with the pandemic era, there have been a number of challenges, disruption in supply chains, with diagnosis, with medication, and that has obviously affected countries. We actually recently published a paper in the BMJ regarding these measures. What has changed? What has remained stable? And also where the countries that had a decline in services, we do have an inability. Your area of course, transplant, kidney transplantation, we did have many countries affected by the pandemic severely because of a limitation with mobility of our workforce. They closed down their transplantation program entirely. So it did affect changes in resources available for kidney care. Now, on the next iteration that is about to happen next year, we'll now measure post-pandemic environment, what has happened there after, whether the countries have improved since the pandemic has stopped, new facilities being built, and uptake of transplantation around the country overall. That will measure with the next iteration of the survey. But that's a very important question, and that's the essential remit of the exercise, really to measure the status and now to monitor changes over time at country level, regional, and also global level.
Yeah, I think, go ahead.
Yeah. Sorry, I can add like an obvious examples. So one of my impression is Bangladesh. If you have known that they got the award of the Renal Sister Unit, Renal Sister Center Program Award last WCN, and Bangladesh, with the help of ISN through that sister renal center, have evolved from 0 transplant patients to 400s within like 2 years. So like I have talked to them and they have used our data to present to the government as well. The other one is of course Thailand. So I presented the paper about CKD detection program, which we have never had that program before in our country. And now we are in the point where we try to implement the CKD detection program in the community. So what I want to point out is that our GKHA alone cannot lead to policy change, but we have to use that data, and comes with the collaborations, comes with supports from many organizations, and that would actually lead to the policy change.
Yeah, I mean, I think it's quite remarkable over the years. Like some people have, had PD programs and no longer have a PD program. Like there's positive change and there's also negative change based on various climate, economic and other things. And I think it is a really good way, Kevin, to sort of see how things change and to use the data for advocacy and for other things. Some of you will remember that we had some trainees in BC from Uganda who did not have any community dialysis units before Daniel was here. He went back to Uganda, and there are now 2 community dialysis units in Uganda where there were 0 before. These are things that are impacted by the combination of the atlas to be able to measure and then the various ISN programs. So I think they go hand in hand. There's a question from Carolyn about industry and interaction. No formal interaction, Carolyn, with the GKHA, but certainly, demonstrating like the value that GKHA brings is a way to perhaps think about how we might interact with them. So it's a really interesting point that you've brought up in the chat. Let me see if there's any other, another question. Yeah. Anyways, yeah. 5th question, just a sec. Elaborate on how you're sharing with the general population. How do we share GKHA with the general population as opposed to the kidney community? We're pretty good at that.
Yeah, so that's another very good question. So with at the beginning, obviously we're measuring kidney care structures with patient wouldn't know. So we want to policymakers, we want people, academic community like nephrologists, and other healthcare professionals as well, nurses, dietitians, they're all be involved. Then this second iteration, then we accumulated all this data. Then this question is, what about the most important stakeholders to consume of all this knowledge? Patient is the center of whatever we do, as clinicians, as policymakers done, and so on. So there was need for a patient voice. What do they think about the impact of kidney disease on themselves? In terms of their person, in terms of their families, not just about the aspect regarding medication, or they have access to a doctor who could, treat their blood pressure, treat their albuminuria, and so on. But what about the living with kidney disease? That measured experience as well we decided was quite critical, and that was included in the third iteration of the exercise. So we did have a questionnaire, and we didn't include the slide, but we did have that information as well. And we engaged with international patient partner organization, Kidney Foundation, like Kidney Foundation of Canada, and similar organizations across the world countries, and interviewed patients as well that provided information on impact of kidney disease on their life, from economic, physical health, mental health aspect, which contributed significantly to the Atlas information.
Yeah, and the point you raised, Helen, and what Aminu said, I think the more people know about the Atlas, the more you can share it. I think we're also sharing it with our patient partners and others, so that it's a bit of an aha phenomenon, right? There was an article in the New York Times recently about the silent kidney disease. So slowly, between the World Health Organization, the UN statements, and resources like this, slowly people will begin to hear about it. But I think the more this audience, 50 of you were on the call or on the session today, propagating it and going and playing with the map and seeing, and there's stuff about workforce and trainees and funding and access. Like it's very, I think in the presentation, the totality of the data isn't as like you should go and see how much data about each country there is. And I think with that, you can advocate to your friends and family so that the more people know, right?
Yeah,
So
and on the ISN website, because once an iteration is released, then we try also to publish policy briefs. That is there on the ISN. All this publication, interactive map shared by Somkanya, and as well media interviews, because this is very important, public dissemination. So with every iteration, every World Congress of Nephrology, Adela will sit down with us also to deliver an interview, summarizing the results, the implication for patient care for policy. And all this is available on the Atlas website if you go to the ISN. And all the interviews, because every iteration, we get interviews with media outlets, for even the major ones, including CNN, for example. We get interviews, and they're all recorded and available there on the ISN website. And this is essentially targeted for external communication, public information, aside the regular traditional academic output.
Great. So we're just coming to the end. So I just wanted to thank the two of you for putting together a lovely overview, but also reminding the audience that this is a resource available to you and for you. And please use it, but also if you have ideas as to what we might want to do provincially or nationally to sort of bolster the same concept within our own boundaries, that's also very doable. So thanks very much to the two of you for the presentation, for all the work that you've done to get it to here, and to the audience for your participation. So thank you, and what a wonderful way to start our academic overview. So thanks, everybody.
Thank you. Thank you very much for the opportunity to be here. Thank you.